This is a topic that is in flux, so we'll show you where the state of the art is. With the 16 detector CT and higher, people are doing now chest, abdomen, and pelvis at the same time. And the images are usually isotropic or nearly isotropic, and this is very important. And with this, you could get high quality spine in any arbitrary plane, multiplanar reconstructions, and without repeating the exam, especially for the spine. The MPRs have been shown to be more sensitive than plain films in detecting fractures, which is, again, another thing that has been discovered lately. The number of patients that are now done acutely with plain films or radiography, if you like, is rapidly decreasing. So when you do these chest, abdomen, and pelvis, you get images like this. This happened to have a burst fracture here, and these are acquired from the chest, abdomen study. You don't need to do anything special to get the spine films. There are a few tricks you have to learn. You don't need to learn all the physics of CT. I never learned that. But you have to learn a few things. What do you need? Well, I need clear, crisp images on which I can read fractures. This set of images and this set were taken with the same parameters, and the technician sent me this. I asked, why did you send me this? Because this is what I sent the chest radiologist. But I knew what I needed, so I asked her for, this was the thickness, so I asked her for reconstruction at 0.5, and she sent me these images, which I think all of you would agree are better for studying bones. What do we do with plain films anymore? Well, we still do plain films, and plain films are basically now done to follow treatment and assess healing of spinal injuries. Well, where do fractures occur? And radiologists need to know that because we are usually betting people. Because of the transitional nature and the biomechanics of the thoraco lumbar spine, this is where most fractures occur. 40% of all fractures occur in the thoraco lumbar junction. Thoracic spine, which we will call from T1 to T10, is stiff, and fractures there are less common. They're about 10 to 20%, and anything below L2 is usually rare. What are the anatomic features of the thoracic spine? We'll start from top and go to the bottom. Well, the rib cage is an integral part of the thoracic spine. It gives it stiffness and protection. In the coronal orientation, we have the facets, and these again are another restraining factor which makes the spine fairly stiff. One fact that I find very helpful is that the spine in the thoracic area, all the vertebrae are a little narrower anteriorly, shorter anteriorly than posteriorly, by about 2 to 3 millimeters. Added to that is the thoracolumbar junction. There is what we call physiologic wedging, and that wedging is fairly common, especially in males. So the mimics of vertebral fractures are two things: physiologic wedging and Sherman's disease. And in the middle of the night, I tell you, our residents always struggle with this. This is your typical case of physiologic wedging here. And if you don't see crisp fracture lines or sharp angles, this is usually physiologic wedging. Occasionally, people get scared at night and they go into CT. But on this alone, I think you should be able to diagnose physiologic wedging if you don't see fractures or sharp corners. Let's talk a little bit about Sherman's disease. Again, a confusing factor in the middle of the night. It's also called adolescent kyphosis. There is abnormal growth, cartilage. There is weakening of the end plate, Schmorl's nodes, and the disc spaces become narrow. The vertebral growth is also affected. So the vertebrae also is wedged. Let me show you a couple of examples. These are recent examples here. A young patient was in a car accident, admitted in the middle of the night. The residents got excited about it, our residents and the orthopedic residents. And they admitted the patient and did CT. And this is obviously, these are multiple Schmorl's nose, narrow discs, wedged vertebrae. This is typical Sherman's disease in an adolescent. However, this could persist into adulthood. And this is an adult who came in the middle of the night after a car accident and had the same problem, and again gave people lots of difficulty. But this is, again, Sherman's disease in adult. Injuries of the thoracic spine are a little different from the thoraco lumbar junction. How are they different? Usually you need, because of its stiffness, you need considerable energy to produce a fracture or fracture dislocation. So always try to look for non-contiguous fracture. There is so much energy, so it gets dissipated to other places. So look somewhere else, and I'll show you examples of those. The incidence of neurological deficit in people with thoracic spine fractures is very high. From one paper here by Lee Rogers, it's 63%, and it's often almost complete. The reason for this is that the thoracic spine has a narrow canal, and the ratio between the canal and the cord size is diminished. And the blood supply to the mid-thoracic cord is meager. So what are non-contiguous fractures? Well, obviously, these are fractures that are not in the same area, and these have been, for a long time, underdiagnosed by radiography. The incidence in the literature has been reported anywhere between 5 and 25, but now, because we do lots of CT, we do lots of MR, we know it's closer to 20 than it is to 5. And I'll show you an example of that. An elderly patient came with a pain in the back, and this is what it showed. And you look in the middle of the thoracic spine, and there is an injury. And knowing that these injuries don't occur with meager or little trauma, we were obligated to do a CT of his entire spine. We diagnosed that pre the CT as a posterior fracture dislocation. We'll go into the classification in a few minutes. And ideally, you should do CT. And ideally, you should do it isotropically. However, the CT we have in our emergency room until now, although they're working on changing it, is a 4-detector CT. And with 4-detector CT, as you can notice, to go sub-millimeter, you have to be somewhere here, and the dose becomes very high. And to do isotropic imaging, you have to go sub-millimeter in slices in thickness. So we do what we call near isotropic imaging. We image this, and I'll show you the images, at 2 millimeters, where the dose is tolerable. And we reconstructed that with quite a bit of overlap. We reconstructed that with 0.5 millimeters. I'd be glad to discuss any of these tricks with you after the session. So we found, as expected, another fracture here in superior facet of 2 extending into the transverse foramen. And this is what you see on the coronal, but because we want to look at the sagittal all in one piece instead of bits and pieces, we do what we call curved planar reconstruction, which is a trick we borrow from our angiographers. And this is what you will see. This is the fracture here, the posterior fracture dislocation. Okay, let's talk a little bit about classification. Why is classification important? Because this is the way we communicate with our orthopedists, and we standardize the way we talk with each other. The thoracic spine classification is a little bit different from the thoraco lumbar spine classification, but there, if you study both, you find there's quite a bit of similarities. The first fracture is the wedge compression, which is essentially the same in both areas. The sagittal slice is peculiar to the thoracic spine, and this is a devastating injury. It's unstable. It's a fracture dislocation. The facets are involved. Posterior elements are involved. And the mechanism here is axial loading with flexion. This is all in your syllabus, by the way. Complete anterior dislocation is actually a worst-case scenario of the sagittal. And I'll show you examples of all of these. The posterior fracture dislocation is like the gentleman I just showed you here who had non-contiguous fractures. And these are not terribly common. They're usually extension injuries. In the past, they used to call them lumbar jack fractures from trees falling on the back of the lumberjack. The burst fracture is very similar to the one in the thoraco lumbar spine. It's due to severe axial injury. Ignore the C spine injury for a moment and concentrate on the thoracic spine injury. And these are all wedge compression fractures due to failure of the anterior column. This is the sagittal slice. They all look the same. There's a fracture, dislocation with involvement of the posterior elements, which I'll show you in a minute. We still do lots of plain chest exams in the emergency room. And what you will see with these cases, especially if the fracture is high, you will see widening of the mediastinum, which makes people think of aortic rupture. If you do a penetrated view, you can see the fracture, and you can see it on the lateral view, but we're never satisfied because you cannot read the extent of the injury from plain films. You have to go to CT. And please concentrate in this area and look at the anterior columns and the posterior columns. You can see it is a devastating injury involving both columns. This is the sagittal reconstructions, and again, you could tell the extent of the injury. Most of these people, because of their neurological symptoms, will get an MRI to show the extent of the damage to the cord. This is the anterior fracture dislocation, which is probably a one step beyond the sagittal slice. It's definitely a very serious injury. This patient was paraplegic. He was admitted to us about 4 or 5 weeks ago, and he was stabilized and sent out. Really no need for MRI in these cases. This is the posterior fracture dislocation, another patient other than the one I showed you earlier, and this is going through the disc, but it's going all the way into the posterior elements. And when you do MRI, you will find that the cord is definitely crushed. And this is the burst fracture, which is very similar to the burst fracture in the thoracolumbar junction, which we will discuss towards the end of this lecture. And usually these are due to axial loading, and you can see the effect on the cord here. So you will find that we do a lot of MRI in these patients because of the neurological symptoms. In the acute phase, we're looking for reversible causes like a herniated disc or a spike of bone compressing on the cord. Sometimes to look at the ligaments and also to predict prognosis. Look at the cord and see whether there is bleeding in the cord where the prognosis is poor, or just a little edema where the prognosis is better. In the chronic phase, we do it to look for things like you heard yesterday, for post-traumatic syringomyelia and cord atrophy. This is a patient who acutely developed a fracture. What he had was a sagittal slice injury, and invariably these patients have neurological symptoms. Unfortunately, disc herniations are not that common with the thoracic spine injuries. They're much more common in the cervical spine injuries. Because we still do lots of chest radiographs in the emergency room, it is very important to look for indirect signs. This will help us on transporting the patient to the CT and things like that. Some of the findings are paravertebral hematoma, mediastinal widening, a pleural fluid, hemothorax, rib fractures and costovertebral fracture dislocations, sternal fractures, and double spinous process fractures. All these are signs of thoracic spine injuries, and I'll show you examples of those. The paravertebral hematoma and mediastinal widening, they have the same pathophysiology. It's due to bleeding around the fractured vertebra. So if it is below T5, it will give paraspinal widening. If it's above T5, it will give mediastinal widening, which could be suspected sometimes for aortic rupture. It is very rare for aortic rupture to occur in conjunction with a thoracic spine injury, although I have seen it once or twice. This patient had both. He had mediastinal widening, and he had something behind the heart here. And if you look at the plain film, penetrated view, you can see there may be something wrong here, but you have to guess, but there is something definitely at T8 here. If you do CT, it's obvious. All this bleeding is due to this fracture and this fracture here. This is giving the mediastinal widening, and this is giving the paravertebral widening or hematoma. Pleural fluid, which is usually hemothorax. It's usually due to rib fractures, postovertebral dislocations. And so I'll discuss them together because of their similar pathophysiology. This patient came with pleural effusion, and if you look at his CT, lots of fluid in the chest. These are broken here and dislocated. The costovertebral junctions are disrupted. And because the ribs contribute to stability, so if you see this injury, then the stability of the spine should become very suspect. Let's look at sternal fractures. There are two types of sternal fractures, and this picture is taken from Dr. Mueller's article in Emergency Radiology. The direct type, which is the most common type, is due to deceleration, where the body hits against the steering wheel and the body of the sternum is pushed back. Whereas in the indirect type, it is due to a fracture of the spine, where the ribs are pulled back and they pull with them the manubrium. I'll show you an example. So this is the indirect type. And once we see this, we have to look very carefully at the spine and react accordingly and immobilize the patient accordingly if we want to do CT or anything like that. The final sign that I will show you is not a very common sign, but once you see it, you will probably be a hero because you can diagnose a serious injury in this area. This patient actually, when he was admitted with a aortic rupture and once was sent to angiography, not knowing that he has a spine fracture. And I could sympathize with that because this sign and this widening all go with aortic rupture, but they also go with a thoracic spine fracture. And on CT, you can see the fractures here and here and the fluid in the pleural. He had a transient paraplegia, so we did MRI, and you can see that he had a fracture of T2, a disc herniation in the lower C-spine, and a long epidural hematoma. There are two challenges when you read thoracic spine injuries on a routine basis. One of them is probably a weekly problem, at least for me, is differentiating osteopenic from neoplastic collapse. The other one is a rare encounter. However, every time I had one of these, it was a very embarrassing case, and I will tell you a couple of anecdotes as we go. So let's talk about differentiating osteopenic from neoplastic collapse. And I had two tables here which are in your syllabus. And instead of going through word slides here, you can read it on your own. But I'll show you examples of all of these in a second here. So if you look at the compression fracture, let's say like this, it's obviously benign because the marrow is normal. How about this? The marrow is abnormal here, but this band pattern is considered to be benign, especially that part of the vertebra still has normal marrow within it. This is a typical benign collapse. How about this? There is some dark signals here, but part of the vertebra is normal. This is another sign that it is benign. So unless the whole vertebra is involved, don't think of malignant. And this is one of my fellows took care of this patient, waited a few weeks, and everything disappeared. This is another patient I was closely involved with, an elderly lady with an extension injury here in the lower thoracic upper lumbar spine. And when that happens, sometimes, especially in elderly osteopenic people, a space is left empty when this goes into extension. And what happens, this is, you can tell it's a fracture. What happens is this area fills with fluid, blood, and then it becomes fluid. And it looks dark on T1 and very bright on T2. And this patient was a medicine patient, so they called me. They said, we have a patient with metastasis, possibly the age goes for it, and the MR goes for it. I said, let's see it. I tried to resist. They showed me this, and I couldn't help it, and I did a biopsy. But I don't do a biopsy on these patients anymore. This is fluid. And when you see fluid, this is usually a benign process. It's not a metastatic disease. If you see air in the vertebra, again, this is a benign collapse. You can ignore it or watch it for more collapse. If you see more hits than one, like here and here, and if the collapse gives you a posterior bulge like you do here, rather than just a retropulsion of the superior upper corner, then it is metastasis. So 2 hits or more than 1 hit, it's metastasis. If you see the posterior elements are involved, in addition to the body, addition another hit here, this is metastasis. Okay, let's talk about predicting delayed collapse. This could be very difficult sometimes and very embarrassing, but I think it's good for a radiologist to know about this because this is a fracture without any changes on radiographs or CT, okay? But the collapse comes few weeks after the initial injury. And this is where the embarrassment comes in. And most people think it's due to avascular necrosis. No biopsies are there in the literature, so we don't know. But lately, there is an individual here from France who published a large series. Before this, everything was anecdotal, a case here, a case there. I published one case, but nobody really knows enough about it. But this paper really shed a little light on this condition. So basically, you should know that an elderly person coming with pain after an injury with normal thoracic or lumbar spine, keep in mind if pain could persist, that this condition could be there and the patient could come with collapse. And I'll show you 2 examples of those. Both of them are burnt on my anterior cortex because they were terribly embarrassing. Okay, so this is an elderly lady, secretary of the ophthalmology department, chairman, came to our emergency room. We looked at this, it was okay. Fortunately, somebody did a chest CT, and chest CTs are known to be able to detect spinal fractures. It was normal, so we were lucky with that. She went to her hometown, which was about 30 miles away. She kept having pain. 3 weeks later, she went to the emergency room there, 2 collapses here. So her boss was not very happy with us, and he called us, and I tried to explain it to him, but I don't think it helped very much. Another patient, elderly patient, working the yard, fell, came to the emergency room in June, and we looked at this. Everything looked fine. He had focal pain there. We sent him home. He came again. There was nothing. Came again. Boy, we became worried. Somebody decided to do a bone scan, which was positive, but noticed no collapse. And then when we brought him back, 2 weeks later, he had the collapse. So delayed collapse is a real entity. Keep it in mind if the pain persists, okay? And if you know about it, it could protect you a little bit. Let's talk about the thoraco lumbar spine very quickly. There are 4 types of fractures, which are very easy to remember. Many orthopedists know these. This is derived from the work of Dr. Denis. In Iowa, we call him Dennis. Compression fracture, burst fracture, seatbelt fracture, and fracture dislocation. And this classification was created in 1983, but it is enduring, and it is helpful because it is easy, and it tells you a little bit about instability. So these are the columns here, the anterior, middle, and posterior. And according to Denis, the stability of the spine depends on the involvement of the middle column. So if the middle is involved, then you have instability. Let's talk about the first type, which is the compression fracture. And the compression fracture is nothing but failure of the anterior column. Okay, and this is basically a stable injury. You can diagnose it on plain films, and if I do, I usually look at the posterior body line, and if it's not interrupted or bulging posteriorly, I stop there. You don't really need CT, although many people will probably ask for CT. The burst injury is a much more serious injury. It's caused by substantial loading. And what you see on CT, all these patients get CT because it's a serious injury, and I'll show you why in a minute. What you see on CT, the displacement of the retropulsed fragments does not really reflect what happened during the injury. The impact, the maximum impact, actually happened during the injury. And the injury to the cord occurred at that point. So what we see really minimizes what happened during the injury. Many of these people have neurological deficits, so we do CT and we also do MRI. On this patient here, it's obvious more than the anterior column is involved. This is involved, and there's a bulge, little bulge here. And here you have actually concavity, which is normal. The bulge posteriorly is always abnormal. And if you look at the interpedicular distance, it's wide, which means also the posterior column is involved. So the anterior, middle, and posterior and this is what is called a burst fracture. Okay, and this is what you will see here, retropulsed fragment, and all the columns are involved. Play it again for you. Notice here, here, and posteriorly. So this is a burst fracture. Nowadays, especially if the patient has neurological symptoms, the surgeons will go in, clean up this, sometimes do a corpectomy and graft it and put hardware. And as radiologists, nowadays we do a lot of CT. We average about 8 to 14 CTs a day, doing things like this, but we're also doing acute trauma, trying to see how well the screws are they in the pedicles, are they inside, outside, and it's, the multi-slice CT has really helped us with this. The flexion distraction is what is called the chance fracture, and it's basically failure of the posterior and middle column in tension and failure of the anterior column either in tension or compression, depending where the fulcrum of rotation is. And neurological symptoms are not very common with this, but abdominal injuries are common because this is where the belt is and where the rotation occurs. This is your typical chance fracture. Okay, so distraction here, compression here. Distraction, distraction, and then compression anteriorly. I always look at the abdomen because this patient had a laceration of the pancreas. Fracture dislocation is the most serious injury in the thoraco lumbar junction, accounting for about 20%, and all three columns are involved, typically with rotation or also shearing forces. The neurological deficit rate in these people is fairly high, and most of these people get CT and get MR, and this is a fracture, typical fracture dislocation. They run them to CT very quickly because the people have neurological symptoms, and here you can see that the conus is crushed, and this is an indication to reduce him fairly quickly. Epidural hematomas, we see a lot of these, and we did a study on this. They're actually very common, and we were worried at the beginning, but when we did the control studies between people who have epidural hematomas from these injuries with people who have fractures but no epidural hematomas, both of them had the same rate of going to surgical intervention. So we concluded that we report them, but we don't think they are a big deal. We don't think that they are symptom producing entity. Although they can produce some symptoms, but they're not as serious as the literature usually indicated. And this is such a patient here who has a burst fracture. And you can see here the epidural hematoma and the epidural hematoma here. Finally, a dural tear, and I got interested with this because the surgeons would come out from surgery and tell me, why didn't you tell me there was an epidural tear? Well, I told him I can't diagnose an epidural tear. And I looked into the literature and followed it for a while, and we started looking for this. Rarely you can see an epidural tear. And that's when the thoracic surgeon will ask for the help of a neurosurgeon to come in and help him repair the rent in the dura. When does this happen? Actually, it happens when there is a burst fracture with involvement of the posterior elements, and then you have the roots herniating through the tear and between the fragments, and this will preclude recovery. Okay, in the past, anytime they saw that burst fracture with neurological symptoms, they thought it's a sensitive, and it is a sign of a dural tear, but it's not specific. And when people did myelographies, they found blood, which is understandable in the thecal sac. And this is how the situation occurs here. And this is from an artist explaining what's happening here. So if you have a tear and a retropulsed fragment like this pushing the roots out, they're going to be caught between the lamina here and prevent reduction and prevent normal healing. And this, we were lucky here. We did this patient. Imagine this patient is lying on his back, and if you see mildly bright signals in the bottom of the thecal sac, which is dark on T2, you're dealing with the epidural, with blood in the thecal sac, which is a good indication of a dural tear. This patient had a fracture above this picture. Thank you for your attention.